Infectious disease. Morbidity and mortality rates for infectious diseases will vary by geographical location. Remember that the immune system is able to detect a foreign invader and respond with both innate and adaptive responses to help clear any infections in our system. When viewing the top 10 causes of death by the World Health Organization, you can plainly see the percentages of deaths due to infectious diseases for low-income areas are 30.78%. The main ones are malaria and tuberculosis are the significant causes of death. When looking at the percentage of deaths due to infectious disease for high-income areas, it is at 4.27. So what happens to be the difference between low-income areas and high-income areas? When thinking about infection, penicillin used to be the antibiotic of choice to help clear infections. But because of its overuse, many of the infectious diseases are immune or resistant to penicillin and penicillin derivatives. That is why antibiotics are now only given for infectious diseases and not given for non-infectious diseases. These are the various pathogens that will be discussed in this chapter. During a vaginal delivery, neonates will experience their first exposure to microbes. Strep pneumoniae normally colonizes in the pharynx, yet in the lungs it causes pneumonia. Staphylococcus aureus is normal on the skin, yet internally it will cause an infection. E. coli normally resides in the large intestine, but it can cause a urinary tract infection if it enters the urethra or the bladder. Common colonization sites would be the eyes, nose, mouth, pharynx, skin, gastrointestinal tract, lower urinary tract, and the vagina. As nurses, it is our due diligence to know the signs and symptoms of an infection. These can include the following: fever, malaise, anorexia, pain, swelling, exudates. Remember that an immunocompromised individual is more vulnerable to infection and likely to develop infections from microbes that are routine normal flora and colonized. When looking at virulence factors, how mobile is the microbe? How well does it respond to the new environment of the host? Is it able to evade detection and destruction? Does it secrete any endotoxins or exotoxins? Older adults are extremely vulnerable and often have diminished immune systems. Patients with the highest risks are those that have chronic diseases, that receive immunosuppressive treatments, or that have increased exposure to bacteria. Bacteria are single-celled organisms. Their structure consists of an outer cell wall that can vary in layer and thickness. They have a cytoplasm that includes a nucleoid, and they have ribosomes to conduct protein translation. Gram-positive bacteria have thick walls that retain stain. Gram-negative bacteria have thin walls that cannot retain the stain, and they require a counterstain to be visible. Aerobic organisms need oxygen to grow, and anaerobic organisms can thrive in a low oxygen environment. Looking at this example of a bacteria, you can see that it has various pili so it can adhere. It has the flagellum so it can be mobile. In the cytoplasm is the nucleoid, which is made up of DNA. And it has three various outer layers. The severity of infection is influenced by virulence factors that will include structural elements, the ability to enter cells, and the capacity to produce any damaging secretions. Various antimicrobial drugs that work according to their action. Medications that target the cell wall synthesis, penicillins, cephalosporins, carbapenems, and monobactams. Medications that target the nucleic acid synthesis, sulfonamides, quinolones, trimethoprim. Medications that work against bacterial protein synthesis, macrolides, clindamycin, linezolid, tetracyclines, aminoglycosides. Viruses are pathogenic acellular particles that are much smaller than a host cell. These must enter a host cell and use the host cell's enzymes and ribosomes to conduct nucleic acid replication, transcription, and translation so the virus can reproduce using energy provided by the host cell. Enveloped viruses have an additional outer membrane envelope surrounding the nucleocapsid that is usually derived from the host cell plasma membrane during the budding process. Capsid proteins for enveloped viruses and spike proteins projecting from the membranes of enveloped viruses are the antigenetic determinants that provoke the host's immune response to form neutralizing antibodies and to activate cytotoxic T cells to kill the host virus. The host virus infected cells displaying these specific proteins. The life cycle of a virus. It will attach to a target cell, It's often due to highly specific recognition sites on the outer surface of the viral particle that bind specific target cell types. It will enter the host cell by endocytosis. There will be a removal of the capsid coat to expose the nucleic acid. Then there will be a replication of the viral DNA in the nucleus of the host cell, or replication of the viral RNA in the cytoplasm of the host cell. Then there will be transcription and translation of the viral proteins. And lastly, we will have a viron assembly, which a capsomere subunits will then self-assemble surrounding the nucleic acid core. There will be a release by cell lysis, killing the host cell. For enveloped viruses, the virons will acquire a membrane coat by budding off from the actual host cell. Vaccines have been developed to prevent or reduce the risk of many viral infections. Vaccines that we take as individuals in the United States are measles, mumps, rubella, which is an MMR. We take varicella, polio, hepatitis A and B. We have rotavirus infections. We have vaccines for influenza and a vaccine for the human papillovirus. Antiviral drugs can target the uncoating phase after virus entry. An example of this would be imidazine. It can target RNA production, ribavirin, and virin release, which would be your neuraminidase inhibitors. Viral DNA polymerase is inhibited by acyclovir and ganciclovir. Fungi and yeast are eukaryotic cells with defined nuclei and organelles. Fungi can be multicellular organisms that reproduce sexually or asexually by branching hyphae, whereas yeasts are unicellular. Superficial fungal infections that do not result in deeply invasive infections would include Tinea pedis, athlete's foot, Tinea calpis, which is on the scalp, and Tinea corpus, which is ringworm. Another term for this group of fungi is also dermatophytes. These are called that because of their association with the skin and their ability to derive nutrition from the keratin of the skin and the nails. Candida albicans is a yeast, a unicellular fungus. This is often responsible for an oral infection, thrush, and a common cause of vaginal infections. Protozoa are single-celled eukaryotic organisms that are abundant in soil and water, and a small number of these are pathogenic. Major morphological distinctions exist among protozoa. These would include flagellates, amoeboid organisms, sportozoans, and microsporidia. These characteristics relate to the mode of movement employed by the protozoa, as well as their complex life cycles. Culturing microorganisms is a key method to identify the specific causative agent. Antimicrobial resistance occurs because microbes adapt so that they no longer will respond to drug therapy that at one time was effective. Although antibiotic resistance is natural and somewhat inevitable, it is associated with antibiotic exposure. Inappropriate or overuse of antibiotics will help perpetuate the resistance. Antibiotic resistance is now a major global threat to healthcare. It's associated with poorer outcomes and exaggerated costs, and it is predicted to worsen unless we take significant action. Enzymes produced by bacteria can help degrade antibiotics, and the targets of the antibiotic action can be mutated and avoid destruction. The Centers for Disease Control and Prevention recommends 7 core elements for hospital antibiotic stewardship programs: leadership commitment, accountability, drug expertise, action, tracking, reporting, and education. Streptococcus is a gram-positive group A beta hemolytic streptococcus. This is the most common cause of bacterial pharyngitis, and it also is a cause for very serious skin infections. If it is untreated, strep infections can provoke an autoimmune response against the cardiac muscle and valves. This would cause rheumatic heart disease. The autoimmune attack against the renal glomeruli can result in post-streptococcal glomerulonephritis. Skin infections with strep can also lead to cellulitis or necrotizing fasciitis. Strep has an outer capsule that assists with immune evasion, and it is able to invade epithelial cells, which also provides protection from phagocytosis by neutrophils and macrophages. Streptococcus also produces exotoxins. This is capable of lysing red blood cells and other tissue cells. With Streptococcus, the hyaluronic capsule assists with immune invasion. Virulence factors will include the M protein of the fibrae, the acid, and the secreted substance that will assist with invasion, cell lysis, tissue damage, and fever. Staphylococcus aureus is a gram-positive, facultative anaerobic, extracellular, pyogenic bacterium. Staph has specific fibrinogen binding proteins that recognize the amino acid sequence arginine glycine aspartate in the fibronectin. This allows the bacteria to bind closely to cells. Infection with Staphylococcus will produce inflammation with infiltration of polymorphonuclear nucleocytes, macrophages, and fibroblasts. And the infected region can become walled off by fibrin and collagen deposits, sometimes forming a very painful boil. Staph also produces a pore-forming alpha toxin that destroys the host cells. It also produces several exotoxins, including toxic shock syndrome toxin. Staphylococcus FNBPs mediate cellular attachment, where secreted alpha toxin forms pores in host cells, ultimately destroying them. CLFs contribute to aggregated formation, and fibrinogen conversion to fibrin is promoted, leading to a walled-off process that can contribute to boil formation. Even though Mycobacterium is associated with pulmonary infection, it may also virtually affect every organ and persist lifelong in its human host. Mycobacterium tuberculosis is a non-motile, non-spore-forming aerobic bacterium that appears as a thin, straight, or slightly curved rod under the microscope. It is known as tuberculobacilli. The bacteria have complex waxy cell walls that protect against host defenses and common antibiotics. It is characterized by its acid fastness. Acid-fast bacilli smear microscopy is recommended in all patients having suspected pulmonary tuberculosis. Sputum cultures still remain the gold standard for diagnosis. Differentiation of TB infection from TB disease is key to understanding the pathogenesis and management. The infections are caused by inhalation of infectious particles known as droplet nuclei. This is spread via aerosols released when a person with pulmonary TB coughs, sneezes, or talks. The transmission occurs when an uninfected individual inhales the droplet nuclei, which then enter the respiratory tract. Many of the bacilli will be trapped and removed by airway mucociliary clearance, the cough reflex, and other immune protective mediators of the upper airway. The bacilli that escape may penetrate to the alveoli, and this will trigger an influx of pulmonary macrophages, which phagocytose and destroy some of the bacilli. The bacilli will begin to replicate within the alveoli macrophages. This is when the TB infection begins. The early spread of the Mycobacterium tuberculosis to other lung areas and other tissues occurs via the lymphatics. In addition to the lungs, the kidneys, long bones, spines, and meninges are sites where TB organisms can also multiply. The granuloma shell may break down over time, allowing the infectious particles to escape, multiply, and lead to TB disease. TB disease has a common presentation of fever, night sweats, weakness, anorexia, and weight loss. Later, a cough will develop. Immunocompromised patients face the greatest risk. TB treatment relies on a separate class of antibiotics that are able to penetrate the cells and specifically target mycobacteria. Multi-drug resistant TB is becoming more common, and it is characterized by resistance to isoniazid and rifampin. Droplets containing the tuberculosis bacilli are inhaled and deposited in alveoli. Here they are engulfed by the alveolar macrophages. The macrophage activation leads to cytokinin release, attracting additional immune cells, which include the T and B lymphocytes, the natural killer cells, and neutrophils. So a solid granuloma forms around the core of the infected macrophages, the foam cells, the giant cells, the epithelioid macrophages, and dendritic cells that are surrounded by lymphocytes, neutrophils, and natural killer cells. Macrophage death leads to transition of solid granuloma to a casseting granuloma with a liquefying center. From here, the granuloma will ultimately collapse, releasing the bacilli into circulation and perpetuating spread of the infection. Chlamydia is an obligate intracellular bacterium with a gram-negative-like cell wall. It is the most commonly sexual transmitted infection in the United States and a significant cause of blindness in low-resource countries. It targets the squamous and columnar epithelial cells of the endocervix and the upper genital tract of women, and the urethra, rectum, and conjunctiva of men and women. In men, chlamydial infection initially causes urethritis. However, if untreated, it can lead to epididymitis and proctitis. In women, an initial infection will cause cervicitis, urethritis, or endometritis. If the infection progresses to the upper female genital tract, pelvic inflammatory disease, known as PID, can develop, causing chronic pain, tubal occlusion, and infertility. Exposure to chlamydia elementary body can occur by sexual transmission or vertical transfer from the mother to the neonate. Upon entering the genitourinary epithelial cells, the bacterium will enlarge and transform to a reticulate body capable of binary fusion and rapid enlargement. Within a few days, the reticulate bodies revert to elementary body form and burst out, lysing the cell and spreading the infection. Gonorrhea is caused by a bacteria, N. gonorrhoeae, for which humans are the only natural host. It is a gram-negative, non-motile, non-spore-forming bacteria that can grow in aerobic or anaerobic conditions. Most commonly, it infects the mucosal membrane of the genitourinary tract, but it can also infect the eye, throat, and rectum. Transmission of gonorrhea primarily occurs through sexual contact. The risk of male to female transmission is higher than for the transmission from female to male. Vertical transmission can also occur through mother to child during delivery. Dissemination of the pathogen can also lead to arthritis, endocarditis, and meningitis. The N. gonorrhoeae organisms are primarily intracellular pathogens. A membrane endotoxin-like molecule contributes to the inhibition of neutrophils, cytokine activation, and the host's inflammatory response. In men, typically it presents as acute urethritis with symptoms beginning in 2 to 7 days. A purulent urethral discharge is common. In women, the initial exposure occurs at the cervix. If left untreated, the infection will advance to the upper genital tract, causing pelvic inflammatory disease, the leading cause of infertility and ectopic pregnancy. In A is Neisseria gonorrhoeae urethritis. The neutrophils in the affected region have phagocytosed many bacteria, and others are seen in the extracellular fluid. The N. gonorrhoeae evade destruction by producing enzymes which neutralize neutrophil reactive oxygen species. In B, the gonorrhoeae is a diplococcus with long pili projecting from the cell wall. The pili facilitate initial attachment to mucosal surfaces and move along within the tissue layers. C. diff are gram-positive, rod-shaped, anaerobic bacterium. Only the toxin-producing strains can cause disease. C. diff infection encompasses varying degrees of severity, from mild diarrhea to pseudomembranous colitis and death. The leading cause of infectious diarrhea in healthcare settings, and it is the most common hospital-acquired infection. The diarrhea is typically watery, and associated symptoms can include fever, cramping, and abdominal pain. More severe complications may include hypotension, shock, toxic megacolon, intestinal perforation, and acute peritonitis. The presence of normal microbacteria and gut function tends to resist the transformation of C. diff colonization to infection and diarrhea in the top image. The inhibition or loss of these mechanisms by proton pump inhibitors that reduce gastric acid secretion or changes in the microbiota due to aging or antibiotic use can initiate the transformation from the spore colonization state to the active expansion state of the C. diff bacteria. This will result in infection and diarrhea production. Borrelia is the organism that causes Lyme disease. This is a gram-negative spirochete bacterium with a unique cellular membrane that differentiates it. It is a motile parasite whose transmission relies on the complex 2-year life cycle of the deer tick. The eggs of the tick hatch in the spring. The initial transmission of the Borrelia occurs during the larval feeding when a tick engorges on an infected animal. The bacteria enter the gut of the tick and remain there until the next blood meal. A fraction of the spirochetes will exit the gut tick, migrate to the salivary glands, and await to transfer to the new host. An additional blood feeding that can transmit the disease usually occurs in the life cycle of the adult female tick when she deposits eggs, beginning the cycle again. The classic cutaneous sign of erythema migrans, a gradually enlarging bullseye rash, may or may not be present. Migration of the spirochete to the heart, joints, and nervous system will lead to clinical complaints of malaise, headache, musculoskeletal pain, fever, and lymphadenopathy. Lyme disease can cause Lyme carditis, which often presents with atrioventricular block, and it may have other cardiac findings like myocarditis and left ventricular dysfunction. This describes the 2-year life cycle of the deer tick that causes Lyme disease. In the lower right, the image you see is a black dog tick, and the small tick is a deer tick. These ticks are very difficult to locate. Influenza is a contagious respiratory illness. The development of an annual vaccine requires selection of strains to be inoculated from the prior season. Influenza A virus undergoes frequent genetic changes termed antigenic drift and antigenic shift. In part, it is due to the sharing of genes for different HA proteins and NA proteins. This variability is a contributing factor for the difficulty of the flu vaccine production. The envelope proteins, hemagglutinin in blue and neuraminidase in red, and the M2 ion channel play functional roles in the viral life cycle of the host cell infection. Influenza A virus undergoes frequent genetic changes termed the antigenic drift and antigenic shift. This is due to the sharing of genes for the different proteins, the HA and the NA. This variability is one contributing factor in the difficulty of the flu vaccine production. HIV is the pathogen that causes AIDS. 2 forms will exist, HIV-1 and HIV-2. HIV-1 is the most common and in the United States and globally. The classification as a retrovirus refers to the property of an RNA virus having the enzyme reverse transcriptase that carries out transcription of DNA from the RNA template. This is the opposite function of the normal biologic process of RNA transcription from a DNA template. HIV causes a chronic persistent type of viral infection that can be managed but not cured. HIV infected cells can reside in a quiescent mode, sequestered in immune tissues, especially those of gut-associated lymphoid tissue. Activation of viral replication is required for the antiviral medications to be effective. HIV transmission is by male to female or male to male sexual contact. The transmission risk is heightened by the presence of mucosal breaks of involved genital and anal surfaces and by co-infection with other diseases, including sexually transmitted diseases of gonorrhea and chlamydia. The time course of the infection is prolonged after the initial acute phase. After a 2 to 3 week incubation period, individuals develop an acute flu-like illness that will last about 2 weeks, and the virus is replicating rapidly, and the number of the CD4 T cell rapidly declines. As the CD4 T helper cells are the primary stimulators of both humoral and cell-mediated immunity, their loss represents a serious compromise to the host defense system. The virus attachment occurs when GP120 binds to target cells, primarily macrophages, and CD4 T helper site lymphocytes. The host cell membrane protein CD4 is the initial docking site for GP120, and this binding is complemented by binding to a co-receptor, either CCR5 or CXCR4. The first stage of binding allows the transmembrane protein GP41 to bind to the host cell and draw the viron close to the target cell, initiating fusion and entry of the nucleocapsid into the host cell. The uncoating releases the single-stranded viral RNA and enzyme reverse transcriptase. The proviral nucleic acid is synthesized, double-stranded DNA for coding of the HIV proteins. Proviral DNA is integrated into the host chromosomal DNA by the viral integrase protein. Transcription of the messenger RNA for viral proteins begins. Additional transcriptase reproduces the viral RNA needed to produce daughter virons. The translation produces the viral protein, a single transcript containing all of the required viral proteins as one long polypeptide strand. Limited proteolysis by viral protease produces the proteins that will be packaged inside the viron, including reverse transcriptase, integrase, and protease. Additional translation produces GP120 and GP41 for insertion into the host cell membrane. Budding gives the nucleocapsid a membrane coating that contains the appropriate glycoproteins. The time course of the HIV, viremia, and CD4 T cell count are the blue dashed line after the HIV infection. Within weeks of primary infection, there is a dramatic rise in viral load, which is the red line, and a substantial drop in the CD4 T lymphocyte numbers, followed by recovery in T lymphocyte population and drop in viral copies that may last 4 years. In the absence of treatment, the viral load will gradually increase and lymphocyte numbers gradually drop until a critical level is achieved in which the symptoms and opportunistic diseases occur, resulting in death due to AIDS. Malaria is a major global disease. Plasmodium species are unicellular, parasitic protozoans with a complex life cycle. Transmission to humans is via the female Anopheles mosquito. It is characterized as mild, severe, or relapsing. The P. falciparum infection represents 99.7% of the cases in Africa, is a major cause of death in children younger than 5 years of age. The P. vivax is uncommon in Africa as the Duffy antigen, a red blood cell protein it uses for docking, is not generally present in those of African ancestral descent. The primary sites of parasitic colonization are the intestine of the insect host and the liver and red blood cells of the human host. Insect repellents and insecticide treating bed netting are critical preventative measures. No anti-malarial drug is completely effective against malaria, so personal protective measures should be strongly emphasized, including wearing long sleeves, long pants, and insect repellent, and if possible, sleeping in mosquito-free settings. The life cycle begins as a mosquito bites a human, obtaining a blood meal and delivering the malarial sporozoites. The sporozoites travel through the bloodstream to the liver, where they enter the hepatocyte and begin to produce asexually, forming schizanths, which is the asymptomatic phase. Parasites in the form of merozytes exit hepatocytes and infect red blood cells. These are visible on light microscopy as ring forms and more advanced forms. After multiplication, more merozytes are released into the circulation as the red cell ruptures and dies. This is when symptoms may occur. Some parasites differentiate into gametes that circulate freely in the blood. A second mosquito bite and blood meal transmits the gametes back to the mosquito. Within the mosquito gut, male and female gametes fuse and form a zygote. This progresses through the okinate stage and produces oocysts that become sporozoites. Upon release of the sporozoites, they can then be transmitted to a new human host through a mosquito bite. Neonates and infants have protection from pathogens in the form of passive immunity. Maternal antibodies circulate to the fetus via the placenta and breast milk that contains secretory IgA. Beginning during pregnancy, at birth, and during lactation, there is potential for transmission of maternal-associated pathogens to the neonate, known as vertical transmission. Prenatal care includes screening tests for Group B Streptococcus, syphilis, rubella virus, hepatitis B virus, HIV, C. trichomonas, and N. gonorrhea. Norovirus and sapovirus are the two viruses that cause viral gastroenteritis. But norovirus is the most common pathogen. It presents with rapid onset of severe vomiting and then diarrhea. Abdominal cramping, fever, headache, and myalgias will also appear. The measles virus is an RNA virus with one serotype. It is the most highly communicable of all infectious diseases. Measles is transmitted by exposure to respiratory droplets, secretions, and aerosols that contain the virus. Mumps is an RNA virus that is transmitted through respiratory droplets or direct contact with respiratory secretions or saliva from infected individuals. The virus targets several organs and tissues, including the respiratory tract, nervous system, pancreas, testes, and salivary glands. Salivary gland infiltration produces a characteristic swelling in about 2/3 of the cases. Rubella is an RNA virus. It manifests differently depending on whether it is present congenitally or postnatally. Postnatal rubella is transmitted through inhalation of respiratory droplets or direct contact with an infected person's respiratory secretions. Maternal rubella during pregnancy may result in miscarriage, fetal demise, or a constellation of congenital abnormalities that include cataracts, pigmentary retinopathy, microtheliomas, congenital glaucoma, patent ductus arterius, peripheral pulmonary artery stenosis, sensory neural hearing impairment, behavioral disorders, meningoencephalitis, microcephaly, and intellectual disability. The lower the percentage of children who receive vaccines, the greater the compromise is to the herd immunity. This is the phenomenon that limits the spread of highly contagious infectious disease due to the lack of sufficient unimmunized hosts. Pneumonia can be classified either as community-acquired pneumonia or healthcare-acquired pneumonia. Healthcare-acquired pneumonia is defined as an infection where an individual whose symptoms begin after more than 2 days of a hospital stay or 10 to 14 days after being discharged. Community-acquired pneumonia is the third most common hospitalization diagnosis in adults age 65 and older, and it is the leading cause of septic shock. Current guidelines recommend adults age 65 and older receive both the pneumococcal and influenza vaccines. Community-acquired pneumonia in the elderly patient carries an increased risk of morbidity and mortality. The varicella-zoster virus viral DNA is able to reside in the host cell nucleus forming a latent infection that can be reactivated months and years after initial exposure. In children, this causes chickenpox, which is a highly contagious disease with respiratory transmission and cutaneous lesions that may spread the infection. The latent infection affects sensory neurons in the dorsal root ganglia and cranial nerve ganglia. With aging, immune protection against the virus wanes, and reactivation causes shingles, a unilateral painful sensory neuropathy and skin blistering associated with a particular facial or spinal segment. Severe cases may be followed by post-hepatic neuralgia, a chronic pain syndrome that may last for months to years. Risk factors for contracting HIV infection remain the same for adults of all ages. However, elderly are less aware of these factors. Because of this and immunosenescence, the diagnosis of HIV in the elderly may occur later in the disease course, often with higher rates of morbidity and mortality, as well as comorbid disease complications. Due to the advanced age, these patients may have a greater loss of CD4 cells, as well as lower counts of total and functioning CD8 cells, which are crucial for limiting the replication of HIV.